Hey everyone, so in this video I'm going to be going over 17 hematology review questions. These are in the style of like NBME or USMLE. I think that it'll be a good review, not only just of hematology material, but also about how I approach questions. I'm a firm believer that doing questions is the best way to prepare for tests, whether it's shelf exams, board exams like step 1 or step 2, or just your regular preclinical exams. I'm going to try to show you how I break down the question stems. I'm going to highlight as I go. I think that the question stems offer you all the material you need typically to get the question right. Obviously, you need to bring in your own knowledge, but they give you lots of hints, and I'm going to show you how I pick those out as I go. I'm also going to try to explain the reason why the question is right, why the answer choice that's correct is correct, and oftentimes why the other ones are wrong. Sometimes I approach the question from different angles. I explain things as I go, sometimes veering off into tangents when necessary, when I think it's a good learning point. So there's just 17 questions here, I believe. I think that they cover a good range of things. Obviously, it's not comprehensive. If you guys like anything, like a particular way that I teach, or you think that I could improve upon it for a future session, please let me know. I am starting to get into the world of tutoring for step 1 and step 2, as well as shelf exams. So if you're interested in that, please just email me at mitchellborn11@gmail.com, or you can just text me, message me on Facebook, whatever. My contact information will be in the description of this video, and I hope this is helpful. So let's just get started. All right, so question 1, a 5-year-old boy is brought to the physician by his parents because of a 6-week history of increased tiredness, irritability, and worsening leg pain. His parents report that he's been reluctant to walk recently because of the pain in his legs. Examination shows conjunctival pallor and diffuse petechiae, so these should tip you off to the fact that he has anemia and he has thrombocytopenia. There's palpable, non-tender posterior cervical and axillary lymph nodes. Anytime you have palpable, non-tender lymph nodes, that should tip you off to cancer. Especially with this, he was fine and all of a sudden now he can't walk. It's looking like cancer. His hemoglobin is 8.9. His leukocyte count is 45,000, very high. His platelet count is 25,000, very low. Bone marrow aspirate shows numerous immature cells that stain positive for CD10 and CD19, as well as TDT. So all of this is pointing you towards cancer, which we know, but now it's what type of cancer does he have? So he's 5 years old. They give you exactly what they see, numerous immature cells, CD10, CD19, and TDT. All of that points you to some sort of B-cell leukemia. And you know it's a leukemia because of his massive leukocyte count and the numerous immature cells. So then you have to think about what type of B-cell leukemia would a 5-year-old have. And then if you look at all of these, you can differentiate it. Now you do have to know all these chromosomal translocations. I remember memorizing these for the first time and it's kind of a pain, but you have to. And if you just memorize them, it'll make answering these questions a lot easier. So 1221, this is very likely the right answer. This is a B-cell ALL, or acute lymphoblastic leukemia, commonly seen in kids, but we'll move to the next one. So 1517, that's the promyelocytic. It causes like DIC. It's not that because he has no concerning signs of DIC, and 1221 is much more likely. 814 is Burkitt lymphoma. With CMYC, he doesn't have any signs of Burkitt lymphoma, so it's not that. 1418, that is follicular lymphoma. That's like an indolent waxing and waning in older women usually. That wouldn't be common in a 5-year-old kid. And then 922, that's CML, which is the Philadelphia translocation. That's also usually in older men. You get basophilia and things. None of that shows up here. So 1221 is the most likely answer. And this is how you should go through questions. You should know what they're giving you in the question stem. They give you tons of hints usually. And then you should go through every question. Obviously you move quicker on a test, but like you should really want to know why each one is wrong, and that will lead you to which one is right. And then you should know why it's right. And then here's the explanation. We talked about most of this, like this leukocyte count under 50,000, no CNS involvement, and hyperploidy. Let's see. Yeah, so it's basically just saying it's ALL. All right, so next question. So a 3-year-old boy is brought to the physician because of a 4-week history of generalized fatigue and malaise. He was born at term and has been healthy since. His mother has a history of recurrent anemia, so some sort of familial anemia. He appears pale, so he's probably anemic. His vitals, his temperature is afebrile. His pulse is, borderline tachycardic. It's normal for a 3-year-old probably. Pale conjunctiva and jaundice. So, pale conjunctiva is just another clinical sign of anemia. Jaundice means that he could have some sort of hyperbilirubinemia. And in the presence of anemia, you think about hemolysis because you can get unconjugated hyperbilirubinemia. The abdomen soft and non-tender. The spleen is palpated 3 to 4 centimeters below the left costal margin. So it's saying that below the lowest left rib on the anterior side, you can feel the spleen 4 centimeters below. That just means splenomegaly. That's all that means. So his spleen is getting engorged for some reason. Then when you look at his labs, his hemoglobin is low. His MCV is normal. So that's a normocytic anemia. It's 80 to 100. His MCHC, it's over 38. So that's high. So that's a really... that you need to notice that. So I'm just going to confirm that MCHC 31 to 36. So sorry, over 36, but still definitely high. So right now we know he has generalized fatigue and malaise. He has some sort of familial anemia. He is anemic. He has hemolysis, and his red blood cells are, his MCHC is high, which means that they're abnormally concentrated. So the red blood cells, instead of being like this, they're smaller. The volume of them is normal, but it's packed in tighter. So the mean hemoglobin concentration is higher. Leukocyte count's fine, platelets are fine, and his red cell distribution width is high. So when you think about what this could be, pretty much anytime you have a high MCHC, it's going to be hereditary spherocytosis. So then you have to know, that's the thing, is you do have to memorize quite a bit about these things. So like you should know from first aid, boards and beyond, whatever you're using, quite a few facts about hereditary spherocytosis, how to diagnose it, what are the different tests you can use to diagnose it, what do you see on labs, and if you know these things, then this question's fairly easy. So then we look at the different answers. Fluorescent spot test, I believe that's for mono. Maybe it's not, but that's not the right answer. Direct antiglobulin test, I believe that's like talking about a direct Coombs test. No. ESN5 malamide binding test. So this is the one that you would use for hereditary spherocytosis. What this does is, I don't know if it's radioactive, but it's some sort of fluorescent material that binds to the different proteins in the red blood cell membrane. And if they're there, then you'll see they'll fluoresce. And if you don't have those proteins, then it won't. So if you do this, then you will know whether there is the presence of spherocytosis or not. Remember, hereditary spherocytosis is when you lose those proteins like ankyrin and band 4.1, I believe, spectrin, and the membrane of the red blood cell messes up and it's no longer biconcave. So since you lose that integrity of the membrane, the nice biconcave disc transforms into like a sphere and it gets smaller. So if we look at the answer, the ESN5 binding test is a specific confirmatory study, blah, blah, blah. And then here's the things we talked about: fatigue, malaise, pale conjunctiva, splenomegaly, anemia, positive family history. All of that is just suggesting hereditary spherocytosis. You can do the osmotic fragility test as well. It says their specificity is not as high as the ESN binding test. And like I said, the increased MCHC is caused by loss of RBC surface membrane area. All right, so a 49-year-old woman is brought to the ER by her daughter because of increasing arthralgia, headache, and somnolence for the past week. So she's aching, she has a headache, and she's becoming weak and tired. She has a history of lupus without vital organ involvement. She last received low-dose glucocorticoids 2 months ago. Her temperature, she has a fever of 101.5. Her pulse is normal. Her respirations are slightly high. Her blood pressure is normal. She's confused and disoriented. So she has scleral icterus and ecchymoses over the trunk and legs. Neuro exam is otherwise normal. Her hemoglobin is low. Her leukocyte count, her white count, is normal. Her platelet count is very low at 25,000. Her prothrombin time is normal at 15, but let me just check. I always like to check these. Yeah, so 11 to 15, and then PTT is 25 to 40, and her PTT is 39. Her fibrin split products are negative, and her bilirubin, okay, so this shows a total bilirubin of 4.9 and a direct of 0.5. So remember, direct is representative of conjugated bilirubin, and indirect is representing unconjugated bilirubin. So if you only have 0.5 direct, that means the rest is indirect essentially. So that is an unconjugated hyperbilirubinemia. So in the presence of anemia, you need to be thinking about a hemolytic anemia. So they do a blood smear. It shows numerous fragmented red blood cells. Urinalysis shows hematuria and proteinuria, which you kind of expect in a hemolytic anemia. So basically, she's got lupus, she's got arthralgia, headache, she's somnolent, she has a really bad hemolytic anemia as well as thrombocytopenia. So which of the following is the most likely diagnosis? So ITP. ITP would explain the thrombocytopenia, but she doesn't have any like inciting events, and it wouldn't cause all this other stuff too. So I don't think it's ITP. DIC, her fibrin split products would be positive, I believe. And she would probably be bleeding from like mucous membranes or like IV sites. They would mention something about bleeding. I don't think it's DIC. Hemolytic uremic syndrome. Okay, so this makes a little bit more sense. TTP, that makes a little bit more sense. Bernard-Sawyer syndrome, again, she would just be bleeding. She wouldn't have terrible thrombocytopenia and all these symptoms. Glanzmann, same thing. Those are just qualitative platelet disorders. So then differentiating between HUS and TTP, HUS is typically in children, first of all. It's usually incited by an E. coli infection. TTP, you have that mnemonic fat RN, so fever, anemia, thrombocytopenia, renal involvement, and neurological symptoms. She doesn't necessarily have renal involvement that we can tell, but at the same time, we don't have a creatinine to look at her renal function. So she has 4 out of 5 of those clinical symptoms. She has lupus, and then they're saying numerous fragmented red blood cells, which is schistocytes. So by all accounts, this is TTP. The patient presents with a classic pentad of thrombotic thrombocytopenic purpura, or TTP. So like I said, low hemoglobin, high indirect bilirubin, scleral icterus, which is just from the bilirubinemia, schistocytes, thrombocytopenia. Okay, so she does have renal failure with the hematuria and proteinuria. That's true. I should have picked up on that. So hematuria and proteinuria means that she's spilling protein into the urine. The kidneys are not functioning like they should. So this is TTP. And if you just knew the mnemonic fat RN and you knew that it could be associated with lupus, then you're good. So additional information, sometimes these are helpful. Yes, basically what I was saying, that it's very likely not HUS. It usually follows an episode of acute bloody diarrhea from, hemorrhagic E. coli or Shigella, which, and it's most commonly in children. So next question. All right, another good heme question. 7 days after undergoing bilateral total knee arthroplasty, so she had a knee operation a week ago, a 65-year-old man comes to the doctor with dark discoloration and blisters on his abdomen. Okay, so that's obviously very abnormal. He takes a statin, aspirin, and he's taking low molecular weight heparin. Okay, so this already is a really good question. This is something you should know, especially if you're going into like an internal medicine rotation. His vitals are normal. When you look at the skin, you see multiple coalescing blisters with areas of necrosis around the umbilicus. Okay, so basically around his belly button, he's got like patches of necrotic skin tissue. Lab studies show a platelet count of 32,000, so very low. So the moral of the story is that when you have somebody on heparin, low molecular weight heparin, you typically give in a subcutaneous injection into the belly every day in the hospital for like DVT prophylaxis, PE prophylaxis. You can get heparin-induced skin necrosis, or you can get heparin-induced thrombocytopenia, or HIT. So anytime you start something in heparin, you want to monitor their platelet levels. If you start seeing big drops in their platelets, or you start seeing stuff like this where the skin is starting to necrose, you need to be thinking about HIT. So this is heparin-induced thrombocytopenia. So let's look at the answers. Anti-desmoglein antibody formation, that's like a derm condition. You guys don't even know about that yet. Deficiency in Adams 13, so that would be TTP. But he doesn't really have any of the signs of TTP. Antibody formation against heparin platelet factor 4 complex, that is exactly what HIT is, so I think it's that. Antibody platelet antigen complex formation, that would be more ITP, like an immune thrombocytopenic purpura. Deficiency in vitamin K, again, that doesn't really explain this, after being on heparin, after a surgery, and now he has this necrotic skin tissue, no. And then decreased production of GP1B, so that would be like Bernard-Sawyer syndrome, I believe, and no, that wouldn't explain this either, so it's going to be C. So we basically explained all this already. You get the IgG antibodies against platelet factor 4 with heparin, and you just start getting clots where you would expect, or where the heparin is injected. So you can get consumption of platelets and thrombosis, cause DVT, pulmonary embolism, and you basically just monitor the platelets. If they start dropping like 50% or more, you need to probably switch heparin products over to like a direct thrombin inhibitor or something else. Okay, so a 65-year-old man comes to the physician because of a 6-month history of progressive fatigue and abdominal pain. So older guy, 6-month history, progressive fatigue, abdominal pain, cancer needs to be on your radar even if it's not. Physical exam shows pale mucous membranes and splenomegaly. Cancer should definitely be on your radar. He's got likely anemia and his spleen is very large. You do a CBC, his hemoglobin's 9.1, it's very low. His leukocyte count is 3,400. I believe the lower limit is 3,500, but again, just gonna check. 4,500, yeah. So he's got some leukopenia as well. You do a blood smear, it shows nucleated red blood cells and teardrop poikilocytosis. So his red blood cells are nucleated, which means the spleen is not clearing them, clearing like the nucleus, or clearing some precipitates from the red blood cell. And then you have teardrop poikilocytosis. So the red blood cells, the red blood cells are being smushed into teardrop shapes called, I believe, dacrocytes. So you kind of wonder why would that be happening? A JAK kinase 2, just a JAK2 mutation. So with this whole clinical picture, as well as having a JAK2 mutation, there's only a few conditions. There's like polycythemia vera, myelofibrosis, essential thrombocytopenia, or thrombocytosis. And with the teardrop poikilocytosis in particular, this is myelofibrosis. So which of the following is most likely the mechanism of the myelofibrosis? Viral replication in lymphoid cells, that would be like EBV, I believe. Lymphocytic infiltration of the reticular endothelial system, no. Fibrosis in the bone marrow, absolutely, that would cause the dacrocytes. Translocation between 9 and 22 CML, it wouldn't cause this with the JAK2 mutation. And then elevated levels of circulating hepcidin, again, no. So yeah, sometimes they'll tell you that they do a bone marrow biopsy and they don't return anything. That's called a dry tap. You can see that because the bone marrow is fibrotic. They could ask you like what causes the fibrotic tissue. I believe it increases like TGF, like tissue growth factor, and like platelet derived growth factor, and the bone marrow just becomes like dry. And all right, so next question. This is a good one. So 3 days after starting a new drug for malaria prophylaxis, okay, a 19-year-old college student comes to the physician because of dark-colored urine and fatigue. So he's 19 years old. He's been taking a drug for malaria for 3 days, malaria prophylaxis, and now he has dark-colored urine and fatigue. No fever, dysuria, abdominal pain, no history of serious illness. He has scleral icterus, so probably some bilirubinemia going on. He has a low hemoglobin, so he's anemic, and he has an LDH, lactate dehydrogenase of 284. So we're going to look at that. I think it's under serum. These are one of the ones that, who's going to memorize that? 45 to 200. So it's 284. So in the presence of anemia, he has some sort of hemolytic anemia. LDH is a marker of hemolysis. So he has scleral icterus, hemoglobin 9.7, high LDH. So peripheral blood smear shows poikilocytes with bite-shaped irregularities. So bite cells. So this kid probably has G6PD deficiency. And there's some drugs that can trigger like G6PD crises, if you want to call them that. And the only one on here that you would use for malaria prophylaxis, again, I'm not sure if you've learned about malaria yet, it should be Primaquine. Yeah, so Primaquine is used for malaria prophylaxis. It causes oxidative stress. If you don't have G6PD, you can't make reduced glutathione, and it's just going to cause oxidative stress. Your red blood cells are going to lyse. They're going to lead to the scleral icterus. They're going to lead to anemia. They're going to lead to a high LDH, and they're going to lead to bite cells. And do you guys remember what the bite cells are from? It's from the denatured hemoglobin because of the oxidation inside of the red blood cells. You get little Heinz bodies. They make their way to the spleen, and then splenic macrophages bite out those denatured hemoglobin molecules, and then you're left with a red blood cell with a big bite taken out of it. That's a bite cell. All right, so question number 7. So this is a 42-year-old woman, comes to the physician because of a 4-week history of progressive difficulty swallowing solid foods. Now, I don't know if this is going to be more of a GI-related question for you guys, but I think that there's a point in here that you can still appreciate for heme. The patient reports feeling food getting stuck in her throat, like she has to drink a lot of water to swallow her meal, so she's having some sort of obstruction in her esophagus. Over the past 3 months, she's had progressive fatigue and occasional dyspnea while performing her daily activities. Her pulse is 104, respirations are 19, blood pressure is normal. She's got conjunctival pallor, erythema around the corners of the mouth, and dry, scaly lips. So even if you don't know about, what that could be, you should realize a couple things. She's got progressive fatigue and dyspnea during her activities. She's got tachycardia that's mild, and she's got conjunctival pallor. So she has anemia until proven otherwise. Her fingernails appear spoon-shaped and brittle. So that's something to pick up on. She has a 1 out of 6 systolic murmur, the second intercostal space. I know you guys don't know what that is yet. It's fine. They do an EGD, or they look down her esophagus, and they show thin membranes that are protruding into the upper third of the esophagus. Even if you haven't done GI yet, you guys might have learned about something called Plummer-Vinson syndrome, and that's exactly what she has. So it's saying that she has iron deficiency anemia causing Plummer-Vinson syndrome. So when we look at all these, it's just saying further evaluation of this patient is most likely to show which of the following. So there's some weird things that go with iron deficiency anemia. The nails can get brittle and spoon-shaped. And then there's this other thing called pica. Hopefully you guys have heard of this already. If not, it's fine. But down here, craving for non-nutritive substances. These patients, they'll want to chew like ice or cardboard, or they'll have like cravings for just like non-food related items. I had a patient at one of the hospitals nearby. I can't say too much, but basically she had a massively fibroid uterus. They had to take her uterus out. She was bleeding a ton over the course of months, and since she was so severely iron deficiency anemic, she was just eating ice all the time, like buckets of ice, and she didn't know why, but it was just she was craving it. It's because she had pica, because she was massively iron deficient. So it actually happens in the real world. All right, so a 7-year-old girl is brought to the doctor by her mother because of a 6-month history of worsening fatigue and frequent upper respiratory tract infections. 2nd percentile for height, 10th percentile for weight. She has pallor, diffuse hyperpigmented macules, absence of the radial bones of her wrist, and hypoplastic thumbs. So her thumbs are smaller, not there. Her hemoglobin is 8.7, her leukocyte count is very low, and her platelet count is also very low. So she has pancytopenia. All the cell lines are low. This patient's condition is most likely caused by a defect in a gene encoding a protein normally involved in which of the following processes. So she's small, she's got very bad anemia and pancytopenia, and she also has hypoplastic thumbs. That should tip you off to one thing only: Fanconi anemia. It's an inherited or de novo mutation, causes issues with DNA repair. So out of all of these, the only one that makes sense is DNA interstrand cross-link repair. The rest, they're each representing something, but you need to, by like the end of the question, you'd be like, this is Fanconi anemia, and you need to know that it has to do with dsDNA repair. All right, a 38-year-old man with chronic hepatitis C comes to the physician because of a 10-day history of darkening of his skin and painless blisters. He started working as a landscaper 2 weeks ago. Okay, so he's had increased sunlight for 2 weeks, and now for 10 days. So 14 days ago, he started working in the sun. Now 10 days ago, he has darkening of his skin and painless blisters. He drinks 2 beers every night and occasionally more on the weekends. So he drinks alcohol quite a bit. He has bulle and oozing erosions in different stages of healing on his arms, dorsal hands, and face. So the most sun-exposed areas are blistering. There's atrophic white scars and patches of hyperpigmented skin on the arms and face, so maybe this happened in the past. This patient's skin findings are most likely associated with increased concentrations of which of the following? So there's quite a few things: Hep C, alcohol, burning or blistering in the sun on sun-exposed areas, and all of that should tip you off to a certain condition that has to do with heme synthesis. And if you look at all of these, they're talking about heme synthesis disorders because all of these are involved in heme synthesis. So this is Porphyria, cutanea, tarda, and that's due to a buildup of uroporphyrinogen 3 in the skin. This is asking you which of the following. They're asking you what is increased in concentration. Sometimes they'll ask you the enzyme that's defective. Sometimes they'll ask what is being built up. This is asking what's being built up, and you have to know that it's uroporphyrinogen. The other main one is acute intermittent porphyria, and just look at the first aid chart. Just look at the different enzymes. Know if that enzyme gets knocked out, the one the molecule before it is going to build up, and that's exactly what they're asking here. So 31-year-old male. So looks another heme synthesis question. 31-year-old male, 2-day history of blisters and brownish discoloration of the urine. Symptoms appeared after you returned from a 4-day trip with friends in Florida. So this is a very similar picture. Similar episodes of blistering twice in the past 3 years. Resolved spontaneously. Vesicles and bullae in the face and dorsal surfaces of the hands and forearms. This is the exact same question we just had, but like I said, now it's talking about the defect in what enzyme. So we know this is Porphyria cutanea tarda. We know that he has a buildup of uroporphyrin 3. So it's saying which of the following is defective. So, we know it's not alad that's dealing with later in the cycle. So we can leave urosynthase. We can take out deaminase. I believe that's the one that's defective in acute intermittent porphyria. We can take out alas, that's higher up in the cycle. So then when we think about these two, we know that uroporphyrin 3 is becoming, the levels are rising. So what is the enzyme that would come after that that's defective? Is it synthase? Probably not, because synthase is what makes something. So if it's uroporphyrin 3 synthase, it would make sense for that to come higher up in the chain. And if that was defective, then you would have less uroporphyrin, but you have more. So even if you forgot the name, just by reasoning through that, you can kind of reason through that it's decarboxylase, because it's decarboxylating uroporphyrin. It's defective, therefore it builds up. All right, a 45-year-old man comes to the physician because of numbness and tingling in his fingers and toes for the past month. He also describes difficulty with balance while walking. So he's got peripheral neuropathy. He also has difficulty walking. He has a hemoglobin concentration of 9.5, so he has an anemia. His homocysteine and MMA levels are elevated. So already you should be thinking about B12 deficiency anemia. So then you get peripheral blood smear, shows hypersegmented neutrophils. So this is B12 deficiency anemia. Which of the following is most likely to have prevented this patient's condition? Avoidance of sulfate products? No. Avoidance of canned foods? No. Cyanocobalamin supplementation. You have to know what cyanocobalamin is. We'll leave that for now. Avoidance of lead-based paint. Do we think that he has some sort of lead sideroblastic anemia? No. Pyridoxine supplementation. You have to know what pyridoxine is, so we'll leave that. Folic acid supplementation. So this is a really good question. They're not just going to tell you vitamin B12. They're not going to just say folate. They're not going to say vitamin B9. They're going to say the most difficult one right when you don't want them to. So you have to know at least a couple names for each vitamin. So vitamin B12 is cyanocobalamin. I believe it's called cyanocobalamin because it has cobalt in it, in its structure. Pyridoxine is vitamin B6. So you could get a sideroblastic anemia where maybe a guy has tuberculosis, they gave him isoniazid, monotherapy, they didn't give him vitamin B6, which you should. And then they're like, what could you have done? Well, pyridoxine supplementation would be the answer. And then folate supplementation. So how do you know which one it is? So we know that he has hypersegmented neutrophils and an anemia. So that could be B12 or folate. So we'll take out pyridoxine for now. It's not a sideroblastic anemia. So then how do we know whether it's B12 or folate? Because they both cause megaloblastic anemias. So the homocysteine should elevate in both of them, I believe, but the methylmalonic acid level should only elevate in B12. It's specific for B12. And B12 is cyanocobalamin. So you could have prevented this by just supplementing with B12. B12 is going to cause something called subacute combined degeneration. Maybe you've seen it in Anki or something. But basically that is just your vibration and proprioception goes away. So you get difficulty with balance while walking, you get a peripheral neuropathy. You should check their B12 levels. Okay, so an investigator is conducting a phase 1 trial, which is a safety trial, of a novel epoxide reductase inhibitor, so something that acts similar to Warfarin, with favorable pharmacokinetic properties for CVA prophylaxis. 2 days after the trial starts, a subject begins to notice pain and erythema over the right thigh. It rapidly progresses to a purpuric rash with the development of necrotic bullae over the next 24 hours. So like a couple days after starting what is essentially Warfarin, you're getting skin changes that cause necrosis. So that should tip you off to something already. Lab studies show a normal PTT of 29, an elevated prothrombin of 28, which is a PT, and an INR of 2.15. So it's at a therapeutic level of essentially Warfarin. So there's a condition, hopefully you're thinking of already, called Warfarin-induced skin necrosis. So this question is extremely tricky. This is a 5-hammer question. I got this question wrong initially when I just looked at it, and I had to do this over because I was looking for the answer choice I thought would be there and it wasn't. So in Warfarin-induced skin necrosis, it typically happens to people with protein C deficiency. So remember, you have all the different factors, factor 5, 10, whatever. All of those are procoagulant. They help the coagulation cascade form clots on the platelets. Then you have protein C and S, which are anticoagulants. So if you have protein C deficiency, you have less anticoagulant, so you're already in a procoagulant state. And then what does warfarin do, or what does an epoxide reductase inhibitor do? Well, it inhibits a lot of different factors, but it also inhibits protein C and S. And it inhibits protein C and S first. Especially protein C, it has a shorter half-life than all these other ones. So if you're already deficient in protein C, and then you inhibit protein C even further, on warfarin you get an initial hypercoagulable state, which is why we have to bridge people with heparin. We start with heparin and warfarin, and then once they're anticoagulated, then we wean off the heparin, and then warfarin is continued. So this is saying, which of the following best describes the pathogenesis of the disease process in this patient? So which of these best describes warfarin-induced skin necrosis? Decreased platelet count? No, that could be like HIT or ITP. Increased factor 7 activity? That wouldn't really explain anything. Okay, so increased factor 8 activity. This is the right answer, and I'm going to let you think about why it is. So remember, what does protein C do? It's an anticoagulant. But what does it actually do to be an anticoagulant? It inhibits factor 5A and factor 8A. So if you have less protein C inhibiting factor 8, then you're going to have increased factor 8 activity causing the hypercoagulability. So that's the answer. And this is like a 4th order question or something. They are not representative of like UWorld, NBME level difficulty, or even like USMLE. They're not this hard. Generally speaking, like this is like a 1 in 100 question. But they do teach you a lot. Like I learned a lot from just reviewing this question. It really made me think deep. So I think it's a good question, even though it's a little bit too hard. Okay, so this is also a pretty tough, misleading question. So an otherwise healthy 23-year-old man comes to the physician because of a 3-day history of mild persistent bleeding from the site of a tooth extraction, no prior history, no prior surgeries, no history of easy bruising. So he appears well, vitals are normal. His labs show a mild anemia to 12.4. His platelets are fine. His PT is elevated to 25, which is pretty high, and his PTT is normal. So which of the following coagulation factors is deficient? So deficiency of which of the following coagulation factors is most likely the cause of this patient's condition. So if they didn't ask it like that, they could say like, which of the following does he most likely have? I think von Willebrand's disease would be the best answer here, which is what I initially thought this guy had. But there's one thing in the labs that makes that less likely. So von Willebrand's factor helps stabilize factor 8 in the intrinsic pathway. So if you had von Willebrand's disease, you could have a normal or slightly increased, usually slightly increased PTT, and his PTT is fine. But if you have von Willebrand's disease, your PT should be completely normal. It doesn't affect the extrinsic pathway at all. But this guy has a high PT, and the only factor over there in the extrinsic pathway is factor 7. And you guys should really just memorize the chart in first aid, or pick one coagulation cascade chart and just memorize it really well. Make sure it has enough details, which is why I like the first aid one. It's got enough details, but it's not too overwhelming. If your PT is isolated, if it's the only thing elevated and you have a mild anemia and you have some bleeding gums, the only thing that makes sense is that you have an extrinsic pathway coagulation defect or deficiency, and the only one over there is factor 7. So that's the only one that makes sense. This is one of those questions that you can overthink very easily. I was initially looking for a factor 8, thinking that like maybe because he has von Willebrand's, factor 8 would be messed up, but it says deficient. It wouldn't necessarily be deficient. So this is the only one that makes sense. All right, a 4-year-old girl is brought to the physician because of diarrhea and vomiting for 5 days. Vaccines are up to date. She appears pale and irritable. Her vital signs are normal. Exam shows petechiae on her trunk and extremities. Abdominal exam shows diffuse abdominal tenderness with hyperactive bowel sounds. Remainder of the exam shows no abnormalities. She has a low hemoglobin, a slightly increased leukocyte count. Her platelets are low. Her creatinine is high, and she has a high LDH. Okay, so she's got abdominal pain. She's pale and irritable. Her abdomen's diffusely tender, so she's got diarrhea, vomiting, abdominal pain. So some sort of gastrointestinal disorder of some sort. Then you couple that with anemia to 8, which is that's very severe. A leukocyte count, low platelets. She's got renal involvement with the creatinine being high. She's got evidence of hemolysis with the LDH being high. Coag studies are normal. A peripheral blood smear is shown. See if we can get this picture here for you guys. And what do we see? So if you can see my arrow, which you can't, but in the middle of the screen, you can appreciate some schistocytes. So I'm gonna try to move this right to the middle. So you can see schistocytes right in the middle. They're fragmented red blood cells. They've been sliced open. There's one to the bottom right as well. Oh, you can't see my mouse. So right here, there's a schistocyte. Right here, there's schistocyte. There's one right there as well. These are some schistocytes. So these are schistocytes. So it's asking, which of the following is the most likely underlying cause? Hopefully that you thought of HUS, TTP type issue. But remember, the difference is the etiology. So HUS, this is a child. She has evidence of a gastrointestinal illness. This is E. coli. So this is E. coli causing HUS. Pretty straightforward question. That's a completely fair question that they could give you on a test. They give you plenty of hints up there where you should be able to get this question. I think that's a really good one. A 9-year-old boy is brought to the physician by his parents because of a right-sided shoulder pain for one day. He's not had shoulder sweating. Over the past year, he's treated twice in the ER for painful swelling of his hands and feet. So what is that? It's dactylitis. He immigrated with his family from Kenya 2 years ago. His temperature is normal, pulse is normal, blood pressure is normal. Physical exam shows no tenderness, erythema, or joint swelling of the shoulder. So the exam of the shoulder is normal, but it's really hurting him. You look at his lab studies, his hemoglobin's 7, so he's profoundly anemic. He's a normocytic anemia. His reticulocyte count is 9, okay? So that's pretty elevated. His leukocyte count is 12,000, so it's just on the border of being elevated. A peripheral blood smear is likely to show which of the following. Okay, so remember, I highlight things because you want to be looking for keywords. This is a 9-year-old kid, originally from Kenya. He has dactylitis. He has right-sided shoulder pain. He's anemic, and he has an appropriate reticulocyte count response. So he is producing them, but this is probably hemolytic. Hopefully that makes sense. He's anemic, but his reticulocyte count is appropriately high, so he's responding to the anemia, trying to make more. So it's not like aplastic anemia or anything. So out of all those, hopefully you picked up on this is likely sickle cell anemia. So when you look at these, a peripheral blood smear is most likely to show which of the following abnormalities. Ring-shaped inclusions and erythrocytes, that would be like babesia or malaria, probably not. Teardrop-shaped erythrocytes, that would be dacrocytes like in myelofibrosis we had earlier, no. Nuclear remnants and erythrocytes, that would be, I believe that would be, okay, that's possible because that's like Howell-Jolly bodies. Fragmentation of erythrocytes, that would be schistocytes, nothing here suggesting HUS or TTP. And erythrocytes with no central pallor, that would be like hereditary spherocytosis because you lose the biconcavity and now you just have spheres with no central pallor. So that was a weird way to describe sickle cell. Nuclear remnants and erythrocytes. So those are Howell-Jolly bodies, not to be confused with Heinz bodies. Remember, Heinz bodies are red blood cells with denatured hemoglobin due to G6PD deficiency. Howell-Jolly bodies are nuclear remnants left in erythrocytes. And the reason you get nuclear remnants left in red blood cells is because the spleen isn't working. So you're going to see that in a couple conditions. You're going to see it in patients that have had a splenectomy for whatever reason. Sometimes the boards will word it as like a patient that maybe was in a car accident when they were younger and they had their spleen removed because like splenic rupture is deadly, so they remove the spleen. Then you'll get Howell-Jolly bodies for the rest of your life on blood smear. In sickle cell anemia, once you reach like adolescence, a lot of these patients have autosplenectomy, which means their spleen just gets so many sickled red blood cells put into it over time, it just kind of dies. It just becomes ischemic and necrosis and just kind of shrinks and essentially becomes non-functional. So it's no different than having had a splenectomy. So when you look at this kid with sickle cell, the peripheral blood smear should show nuclear remnants or Howell-Jolly bodies. Yeah, look, typically develop functional asplenia by 4 years of age. And that's why they're so susceptible to the encapsulated infections. Everything kind of ties together. All right. A 67-year-old woman with non-Hodgkin lymphoma comes to the physician because of progressively increasing numbness and tingling in her fingers and toes. Her last cycle of chemotherapy with vincristine was 1 week ago. Physical exam showed decreased sensation to light touch in all distal extremities. Knee and ankle deep tendon reflexes are decreased. So it's obviously a peripheral neuropathy. Which of the following is the most likely underlying mechanism of this patient's peripheral neuropathy? So you have to know what vincristine does and why it would be causing peripheral neuropathy. We know that it causes peripheral neuropathy, but you have to know what it does. So vincristine, it doesn't inhibit topoisomerase 2. It doesn't incorporate false pyrimidine analogs. It doesn't inhibit beta-tubulin polymerization. I don't think, actually, I think that is exactly what it is. Yeah, it's that one. The cancer drugs, the section in first aid is pretty easy. Or not easy, but it's pretty palatable. It's only a few pages. I think if you just know the first aid material, you'll be fine for cancer drugs. I used to be worried about that, knowing exactly what, regimen or medication to use for certain cancers. You're not like a hematologist or oncologist. They're asking you questions like this. They want you to know the mechanism of each drug, and they want you to know the main adverse effects of each drug. I think that's pretty much all you need to know. All right, this is kind of a difficult question. A 47-year-old woman with metastatic breast cancer is undergoing chemo. Extreme fatigue since beginning chemo. Her pulse is 98, respirations are 16, blood pressure is 132 over 84. Hemoglobin is 10.4, so she's anemic. Her leukocyte count is 800, so it's extremely low. Platelet count is 50,000, also low. Patient started on a new medication, so then we're going to look at the results of the medication. So hemoglobin is basically unchanged at 10.6. Her leukocyte went up to 2,000. Her monocytes went down to 2%, and her platelets essentially unchanged. So they're asking which of the drugs below could have caused this. So the only thing that changed is that her leukocyte count went up from 800 to 2,000, and the monocytes did not go up. They went down a little bit. So which of these would increase leukocytes but not increase monocytes? So aldesleukin, no, that's just going to mess with T cells. Interferon beta, it's the treatment that's not really going to affect these cell lines. Filgrastim, that's going to do something with leukocytes. Romoplastin, I believe that's with platelets. And then epoetin alpha, it's just EPO. That's going to increase red blood cells. Now, if her hemoglobin went up to 11 or something, then sure, maybe you could think about that, but no. So you have to know the difference between filgrastim and sargramostim. So one of these increases just granulocytes, and one of these will increase granulocytes and monocytes, and filgrastim is the one that just increases granulocytes. You know it's not the other one because if it was the other one, you would see the monocyte increase as well, or at least stay at 5% or higher, but it went down. So the proportion of monocytes went down while the total leukocytes went up. So the monocytes were probably staying around the same absolute level while the neutrophils went way up, which is what you're trying to do in these patients that have risk for neutropenic fever and chemotherapy. You want to boost the neutrophils so they don't get a pneumonia or sepsis.